right. And we will move on to our final speaker. Before I do that, I just want to have another little reminder that we'd appreciate your feedback for today. I'll place an evaluation link in the chat feature during Dr. Hurley's presentation. That will be the way that you request your certificate of attendance. And remember that we have those hours approved for nursing and respiratory therapists. The email is automatically generated from your evaluation, so please watch your inbox for that. The email will be from ND Department of Health, and their certificate is the same format for both nursing and respiratory, and tobacco treatment specialists can use that as well. And I see Dr. Hurley has joined, so thank you so much for joining our End Summit. I saw Dr. Hurley present last October, and I thought he was really great. I shared it with the team and reached out, and he was able to join us today, so thank you. Dr. Hurley is an addiction physician and the medical director of the Substance Use Prevention and Control Division in Los Angeles County Department of Public Health. He is the president-elect of the American Society of Addiction Medicine and gives presentations around the world regarding addiction medicine. He is a senior researcher at the Friends Research Institute and is a primary investigator on a tobacco-related disease prevention program funded project integrating smoking cessation services into community mental health centers and patient-centered medical homes. He is the grant lead for 3 medications for addiction treatment access points projects, supporting access to medications for addiction treatment across Los Angeles County. Dr. Hurley is also a co-investigator for several projects evaluating the integration of substance use disorder and mental health treatment within community health settings. Please welcome Dr. Hurley.
Thank you so much, Kara. Is my audio coming through okay?
Yes, and I see your slides too.
All right, I think we're all set to get started. Thank you so much for having me. I'm actually hailing here from Los Angeles, California, where, as Kara mentioned, I work for the Department of Public Health. I'm going to be talking about enhancing mental health outcomes and recovery from substance use disorders through addressing smoking. I don't have any financial conflicts of interest, but as Kara mentioned, I am the president-elect of the American Society of Addiction Medicine. So comments that I might make on topics involving ASAM may be biased towards ASAM. It's not a financial conflict, but it is certainly a perceived conflict. When we think about the patients that we serve or the clients that we serve who smoke cigarettes, individuals who receive mental health services smoke at least 50% higher the rate as people who don't get mental health treatment. And there's this gap that people who don't receive mental health treatment seem to be smoking less. People in mental health treatment tend to stay smoking. It's not overwhelming, right? We're only talking about a difference of between 20 and 30% across the United States. But nonetheless, there is a distinct elevation for people who receive mental health services to smoke cigarettes. And vaping, you know, this study is what, a decade old. We are seeing those trends extended into e-cigarette use. And it's interesting, the more mental health symptoms that we have, and this is a slide looking at something called the K6 scale, the more psychological distress somebody has, the greater the chance that they have past month cigarette use. And despite the higher rates of tobacco use disorder in people that receive mental health treatment, people who receive mental health treatment generally don't receive smoking treatment. That is, tobacco use disorder tends not to be documented in mental health records. Psychiatrists treat tobacco use disorder in less than 2% of, I'm a psychiatrist myself, of our outpatient practices. We tend to have the lowest awareness in mental health of quit lines in state tobacco services. Most state psychiatric hospitals don't offer smoking cessation treatment. And the prevalence is even higher in substance use disorder settings, right? The co-occurrence of tobacco use disorder in people that receive addiction treatment is as high as 80%, right? If you look at U.S. drug treatment studies. There's a survey that was conducted maybe 15 years ago, but it actually, if you look at the surveys and assessments of current services offered in addiction treatment settings, you'll see many addiction treatment service organizations do ask people about smoking status, but less than half advise people that receive addiction services to change their smoking behavior. A quarter use motivational techniques with patients that might not be ready to change their smoking, and less than 20% actually have all 5 intake procedures. If you look at, again, addiction treatment organizations, more than half have no formal smoking treatment. A vanishing amount, 6%, actually offer counseling with medications. And why don't behavioral health settings treat smoking? Well, oftentimes we say we're too busy, right? Our priority is the depression. Our priority is the suicidality. Our priority is stabilizing the psychosis or the mental health condition. It's addressing somebody's anxiety. It's not smoking. Or the priority is the alcohol, the cocaine, the cannabis, the amphetamines, the sedatives, right? That's the priority. So we don't address it oftentimes because we're too busy, or we're perceived to be too busy. Or we might think this is not our wheelhouse, right? I'm a mental health clinician. I don't know, or I'm not, addressing smoking is not what I do. Many payers, and I should admit some ignorance to the North Dakota system of care, but where I work, our California Department of Healthcare Services won't pay for smoking treatment delivered as part of the addiction treatment benefit. That is, right now, smoking services are carved out usually to primary care providers and not to the specialty SUD system. And then there's also this assumption of people here from mental health services, they're not interested in changing their smoking. We might see it as intrusive. Now, again, as part of the survey from 15 years ago, there's this cultural norm of we don't think of smoking as being important to mental health or addiction treatment. It's not part of our treatment culture. Patients or our clients lack the readiness. We don't have the resources. Oftentimes, the staff attitudes towards smoking are not conducive to actually running a smoking treatment program. And then there's environmental barriers. I mean, I can't remember the last time I went to a residential setting where there wasn't a smoking area, right? Where there wasn't setting specific facilitators to help support people continuing to use. Now, if you look at what's the readiness to change smoking behavior in people in the general population versus people who get mental health services versus people who get addiction treatment services, what you find is actually there's not a terrible amount of difference. The readiness to quit, and again, this is now information from 20 years ago, but it is no less true today, is the readiness to quit in the general population is roughly 60% would like to not smoke anymore. Now, that doesn't mean that they're ready to stop altogether. And this data was specific to cigarettes, not to vaping. But nonetheless, most people with tobacco use disorder would like to not smoke, right? It is, I think, gone is the era where where the majority of people really were enthusiastic about smoking. And I can't tell you of my own patients. I talk to people and they're like, yes, I know smoking is bad and I'd like to quit. But then the conversation is, but when? And oftentimes it's, well, I'm not ready now. But if you actually, would you like to quit in the next 30 days? About a fifth of people say yes. And would you like to quit in the next 6 months? The remaining 40% of people say yes. And that's in the general population. And it tends to be relatively stable, even for people who get general psychiatric services, people with depression, people in the inpatient hospital, people who get methadone treatment. Overall, 70% of tobacco users want to quit at some point, which means there are some people who really are devoted to their tobacco use. They're not interested in complete cessation, but would like to quit at some point. But the way tobacco use disorder works is tobacco use disorder weaves its way into your life. People wake up, and most people with tobacco use disorder wake up in nicotine withdrawal, and there's nothing that seems to satisfy nicotine withdrawal quite as directly as inhaling ignited tobacco leaves, right? Cigarette smoke or vaping now also can help quickly alleviate nicotine withdrawal. So people wake up and they have a cigarette. That's oftentimes they do that either with coffee or even before, oftentimes even before they have a shower in the morning, right? As you wake up and you smoke a cigarette. And then most people that drink coffee, those of us that do, if you have a tobacco use disorder, cigarettes and coffee go together. And maybe you commute to work or commute to wherever you're going. Even in a year of COVID, people oftentimes are still going someplace, and cigarettes are part of that commute. And maybe you need to take a break from your job or what you're doing, so you use tobacco. Maybe something bad happened and you use a tobacco product in order to cope with whatever happened that you didn't like. Maybe something good happened, right? And you use a tobacco product to celebrate, right? Tobacco weaves itself into people's lives. So quitting smoking sounds very easy. Just don't pick up a cigarette. But what you're actually asking somebody to do is learn how to wake up and not smoke, and drink coffee and not smoke, and go through their commute and not smoke, and tolerate good things happening and not smoking, tolerating bad things happening and not smoking, right? You have to relearn how to go about your day and live your life as somebody that doesn't smoke. And so what happens is when most people try a quit attempt, what they'll do is they'll say, okay, this is it. I'm going to wake up and I'm not going to smoke. So people are able to power through that, but then something happens during their day and they get tripped up and they use. I think of quitting smoking actually as an iterative learning behavior, right? You have to learn how to navigate the different pieces of your day, and the strategies you would use might depend on the circumstances of how you might get tripped up. And this is why counseling and medications can be helpful, because medications are pretty effective at alleviating the physiologic withdrawal. And counseling can help somebody navigate the skills of navigating their lives as somebody that doesn't use tobacco products. So without assistance, really only 5% of people are able to quit on their own. It varies from population to population, but that's overall. And so there's a 95% relapse rate, and counseling and meds can more than double that. One of the reasons I think that addressing smoking in the context of behavioral health is so important is that people who use tobacco products really are more stress reactive. I mean, this study's from 10 years ago, but stress during nicotine absence results in reduced ability to resist smoking and intensification of smoking pleasure. That is, being a tobacco product user actually causes stress. And this is counterintuitive, because people are like, oh, I'm so stressed out, I can't quit. And my response is actually, you're so stressed out because you haven't quit, right? Not quitting actually is contributing more to stress and anxiety. And there's some pretty good evidence that actually, if you're able to get somebody to quit smoking, right, smoking treatment reduces depression, anxiety, and stress. Now, let me be clear. I'm not suggesting that quitting smoking is easy or not stressful. It is. It's like any change behavior, an inherently effortful, mindful, and potentially stress-inducing activity. But if you measure things like PHQ-9 scores or HAM-D scores, HAM-A scores, GAD-7 scores, right, scales of anxiety and depression and stress, when somebody is using tobacco, you get them through a quit attempt and then you assess them after. Actually, it seems to have an effect greater on positive mood and quality of life as compared with antidepressants, which in mental health we routinely use for people with depression and anxiety and stress. And the other reason to address smoking as part of somebody's mental health treatment is smoking affects our liver, right? It affects the way that our liver metabolizes medications. We want people to stabilize in their mental health treatment. Addressing and treating smoking is a huge part of that. I'm going to pivot from sort of mental health to addiction real quick, and I'll show a picture of Bill Wilson. Bill Wilson was a stockbroker in New York City in the 1920s. And he was famous, not actually for anything he did in financial services, but he was famous because he was somebody with alcoholism, is the, I think, term he used. We would use the term alcohol use disorder in the addiction medicine community today. But Bill Wilson stopped drinking after a vital spiritual experience in New York City. They called them sanatoriums. Basically a withdrawal management center, right? He went in and got treated for alcohol withdrawal, had a vital spiritual experience, and then kept going back to the sanatorium to talk to people with alcoholism. It's interesting. His talking to people seemed to make no difference to their drinking, but it kept him from drinking. And he was on a business trip in Akron, Ohio, met up with Dr. Bob. And he and Dr. Bob started talking together, and essentially talking together helped them not drink. And so they said there is something to this. People with alcoholism or alcohol use disorder, talking to other people with alcohol use disorder, can help people not drink. And so they, Dr. Bob had been affiliated with something called the Oxford Group, or I don't know, affiliated might be the wrong way of putting it, but sort of worked with a tradition of turning your will over to a higher power, and cataloging your defects or your deficits, and making amends for wrongdoing. And so the 12-step program was born from this meeting between Bill Wilson and Dr. Bob. It's a fabulous story, and there's a whole history on AA if anyone's interested. But if you've ever been to a 12-step meeting, you'll notice, in addition to the tokens that are given to people who are in recovery or celebrating certain amounts of time since they last used, you'll notice two other key features in most 12-step meetings. The first feature is coffee. There's almost always coffee. And there's almost always coffee, even at like the 10 a.m. or midnight meetings. There's just always coffee. The other thing is smoking, right? The amount of smoking in 12-step meetings is actually tremendous. Bill Wilson died of emphysema. He was a 2-pack-a-day smoker for most of his life. And it was always ironic to me that here, this person shined a light and guided so many people with alcohol use disorder into long-term recovery, right? 12 steps are not the only way to be able to achieve remission from an alcohol use disorder, but they are a widely available and free way. It's one way, it's not the only way. And thus far, the traditions of AA typically ignore tobacco use disorder, which killed their founder, right? Like, he died of a tobacco use disorder. In this case, the medical consequence, the emphysema caused by long-term tobacco product use. So I'm of the opinion, and I work for specialty system care, where I'm trying to find a way to carve tobacco treatment back into addiction treatment, because you treat tobacco as part of addiction treatment, you get a 25% increased likelihood of long-term abstinence from alcohol and illicit drugs for people that stop smoking. There's this assumption, we can't do tobacco treatment as part of addiction treatment. It'll interrupt, but actually there's no evidence of that. Smoking treatment during substance use disorder treatment does not seem to impair the person's recovery and enhances the substance use disorder treatment outcome. This is, again, a study from about 10 years ago, but stopping smoking during the first year of substance use treatment predicts alcohol and drug treatment outcomes. People who stop smoking in the context of their treatment are more than twice as likely to remain in remission from their non-tobacco substance use disorder. But regrettably, about 11% of people without a tobacco use disorder pick up a tobacco use disorder when they go to addiction treatment, which is like, I'm glad that there are people who are addressing their non-tobacco substances, but I think it does them such a disservice for them to then add a tobacco use disorder on top of their non-tobacco use disorders. Okay, so I'm here to make the pitch that behavioral health systems of care should be taking the lead. We have a high prevalence of tobacco use disorder, which is in the DSM. It's in the foundational document that we use for diagnosing and other mental health conditions. Most people, like myself as psychiatrists, we understand what addiction is, right? We understand that addiction co-occurs with depression and anxiety. There's tobacco interactions with psychotropics. We tend to, in behavioral health, we tend to have longer and more frequent treatment sessions. We tend to understand things like counseling and support in addition to medications. There's a tremendous need in a relationship to mental health symptoms, and I want to give a credit to Dr. Joe Williams in New Jersey, who I think has spelled this case out very directly. And again, I want to just dispel the idea that people with behavioral health conditions are not motivated to cease smoking. That's not true. They may not be ready to quit right now, but I add it to the, using the medical parlance, the problem list or the treatment plan or whatever you want to call it, to follow up with. So what do you do? I'll actually get into the nitty gritty. What do you do as a clinician when you have a patient using tobacco products? Well, you ask. You identify who's using tobacco, and this should be standard across all intakes, right? Who's using tobacco products? And I very broadly, cigarettes, vapes, chews, other forms of smokeless tobacco, any tobacco product. And I advise, to change tobacco use. I actually have stopped using the word quit, not because I don't want patients to quit, but because if I say, are you ready to quit? And they say no, I might not understand, is this person wanting to quit at some point, but not ready to quit right now? So if I say, are they ready to quit? And they say no, whether or, it obfuscates meaningful differences in readiness. So I say, what are your thoughts on changing your tobacco product use? Say change, what do you mean? I said, well, some people want to smoke more, some people want to smoke less, some people don't want to change it. What are your thoughts about, what are your thoughts in general? And it opens up, it's a very broad question. What changes might you be thinking about making with your tobacco product use that creates a lot of options for what a patient might say next? That then helps me assess somebody's willingness to make a change attempt. If somebody wants to smoke more, that's usually not something I help them with. Okay, I understand you want to smoke more. If you ever want to change that, let me know. But if they do want to smoke less, even if they're not ready to stop, I assess their willingness to make that change attempt and then assist in helping people cut down or quit. In other words, I will work with people who are actively using tobacco products, even if they're not ready to quit right now, in the goal that any progress we make gets them closer to quitting. And then I arrange for follow-up. So what are the core components of smoking cessation? Dr. Taylor, the previous speaker, talked about meds and counseling. I might broaden that to meds, counseling, and support, right? We've got medications we can use. We've got skills we can teach people, and that's what counseling typically helps with. And support is everything else. Support is, are there cigarettes in the home? Support is, do you have a smoking group that you can access? That isn't strictly counseling, but kind of a mutual self-help group, right? Support is, other social determinants of health. It's much easier to engage a quit attempt when you have things like a stable job, stable housing, stable family relationships. So support is a big driver of smoking behavior. When people have instability in their life, oftentimes cigarettes are used as a comfort for that, right? So I think of all three, and I want everyone to have access to all three. But I don't withhold meds just because somebody isn't getting counseling. I don't withhold counseling just because somebody won't take meds. So we've talked about the 5 A's, and if I'm going to assist with a quit attempt, the categories are meds, the categories are counseling, and the categories are what other social determinants of health do I have the capability of addressing. And then actually, when I'm talking to somebody, I use the 5 R's, right? I reflect to somebody the relevance of tobacco product use from their perspective. So one way that I'll evoke this is by using an amplified reflection. Here's an example of an amplified reflection. I might say, are you interested in changing your smoking? Somebody says, what do you mean? I said, well, right now you told me you're using a pack a day or a full 20 milligram carton a day or whatever there is. Are you thinking about going to 2 packs or 2 cartons? Are you thinking about going to 4? Or do you want to hook up like a vape to like a scuba suit? So you're just literally only inhaling polyethylene glycol saturated with nicotine all day long. And if I've asked this question right, then it'll elicit a laugh, right? Okay. They're like, you're crazy. Like that doesn't exist. And no, I mean, I don't want to smoke more. Again, if I can, then I'll just reflect. Instead of asking them, oh, you don't want to smoke more, I might say, oh, you don't want to smoke more. And then if I've done this right, they might say, yeah, like that's unaffordable. I know it would be bad for my health. It might stain my teeth. It might smell bad, whatever it is, right? Whatever it is that somebody says. Because the next thing that they're giving me is the reasons why they might want to change their tobacco product use from their perspective. And people are so much better convinced by the reasons that have come to them than the reasons I might have. Like I might say cancer, life expectancy, lung health. Why? Right? Like I might come up with a bunch of health reasons. For them, it might be I don't like the way I smell when I use. I don't like the cost. I don't like the coloring of my teeth. Whatever it is, if I can reflect the relevance to them, I'm in a much stronger position to be able to build a change plan that's relevant. So I identify the relevance of tobacco product use from the patient's perspective. I then try to balance the risk and rewards from the patient's perspective, right? What's the risk of continuing to use and what are the rewards of cutting down tobacco product use? Are there any roadblocks? Are there any things patients say, yeah, I would love to quit, but gosh, I just don't have the time. I might say, yeah, you don't have the time to do a lot of treatment and you're looking for things that you can do that are time effective. Now they didn't say that, but I'm using a complex reflection to be able to pivot around the roadblocks, and then I have this conversation again and again and again and again, right? Like, oftentimes tobacco use disorder is tobacco treatment is a marathon, not a sprint. So I'm reiterating again and again and again. And what are the things of counseling? Well, there's problem-solving skills, building on past smoking change experiences, recognizing dangerous situations like high-risk situations, developing coping skills, informing people, and emphasizing abstinence from intoxicants. Like, people oftentimes will smoke when they drink, for example. And then in terms of support, it's encourage the patient in a good attempt to communicate caring and concern. I try to link people to groups or other connections that they might have in their life that are non-smoking settings or supports. And then there's the meds. So the meds include nicotine products, and there's actually 5 FDA-approved types of formulations for nicotine replacement therapy. There's varenicline and there's bupropion. This is a table, and I'm not going to go through it. It's actually a pretty long table that goes through the 5 different nicotine replacement therapy formulations. That talks about gums, lozenges, patches, nasal sprays, and inhalers. It talks about bupropion, which is a prescription pill. It talks about varenicline, which is also a prescription pill. And just to be clear, there are no prescriptions required for nicotine gums or lozenges. There are some patches that are available by prescription and others that are over the counter. So there are patients that actually could just, they don't even need to see a prescribing clinician. They could just go to a pharmacy and purchase gums, lozenges, or certain over-the-counter patch formulations over the counter. The nasal sprays, inhalers, and the bupropion and varenicline tablets do require the person seeing a prescribing clinician. So what I worked on here in LA is to try to identify each of our county-operated clinics and services, who are the prescribing clinicians that we can send people for tobacco use disorder to see the moment that the patient becomes ready, right? The idea is quickly linking people to medication services. I oftentimes ask, which is the best medication for smoking cessation? It's a trick question because the best medication for smoking cessation, right, of these 7, right, of the 5 different nicotine replacement therapy formulations and the 2 different, nicotine agents, bupropion and varenicline, the best one is the one the patient takes. I think we sometimes have this idea of, oh, the clinical trials of X were better than Y, but the truth is, if somebody won't take, it doesn't matter what the clinical trial says. If there's an individual patient that won't take the medication, it doesn't matter how effective it is in a trial. So patient preference is the #1 most important thing. So what I tend to do is offer a menu of options, right? I say that there are patches, there are as needed nicotine products, gums, lozenges, inhalers, and nasal sprays. There's pills like a bupropion, which could be given once or twice a day. There's a varenicline, which is a twice-a-day pill. We could combine all of them, right? You can combine patches plus bupropion. There's some studies on patches plus varenicline, although the evidence on it is a little bit mixed. But people can do combinations of pharmacotherapy. But understanding what the patient is ready to do is fundamental when treating tobacco use disorder. And then not every clinician understands how these medications work. And so clinician familiarity, like we relatively recently within the past 5 years got varenicline on our public health systems formulary. And so, our clinicians are much more familiar with patches and gums and lozenges than they were with varenicline. Not every patient can take every medication. For example, bupropion is relatively contraindicated in the case of seizures because it can cause seizures. If somebody did great with the patches in the past, that might suggest doing the patch. If they did great with varenicline in the past, that would be important. Not every patient can tolerate varenicline. So on the flip side, you might want to avoid a medication that has not seemed to be that helpful. And then there might be patient characteristics. For example, bupropion is an antidepressant that can help avoid weight gain. So if there's somebody who's really worried about gaining weight and has a history of depression, and they don't have a seizure history, or maybe bupropion would be important. So those are kind of the factors to consider. But what I don't do is say, you have tobacco use disorder, here's the patch, right? Like, and the reason I don't say, here you have tobacco use disorder, here's the patch, is the patch take hours to really kick in, right? So if somebody's waking up in nicotine withdrawal and they put on the patch, they're not going to feel it. They're not going to really feel it. I mean, they get a blood level within the first hour, but you don't really get to steady state for like a couple hours after you put on the patch. So the optimal way of addressing tobacco use disorder that more closely mimics the blood levels that you see with kind of conventional cigarette use is to combine the patch plus the gum or the lozenge or the inhaler or the nasal spray. Give somebody some nicotine product that they can use to get a quick blood level on nicotine while they're waiting for the patch to kick in. The way I prescribe the patch is I have patients put it on when they wake up and take it off before they go to sleep. There's no real benefit to wearing the patch overnight. It does seem to reduce morning cravings a little bit, but it causes nightmares and actually doesn't seem to change smoking behavior. So because there's side effects and no real clinical outcome, like clinical benefit to wearing it overnight, patients take it off when they sleep, but that means they're going to wake up in nicotine withdrawal. So pop the gum or the lozenge, or use the inhaler or nasal spray, and then also put on the patch at the same time. Combination nicotine replacement therapy should be the rule, not the exception. And you can combine combination nicotine replacement therapy with bupropion. Now, I am not entirely personally convinced of combining the patch with varenicline. There's some positive trials and some negative trials. So what I'll tend to do is varenicline plus the gum or lozenge or inhaler or nasal spray, and you can actually add bupropion to it. But you see what I mean? Combination medications should be more the rule than the exception. And the evidence actually says people with mental health conditions, right? Most of the patients that we see in behavioral health need meds at higher doses for longer duration and in combination. So I don't just give someone 12 weeks of the patches, right? Start someone on the patches and then follow up and assess what was their response. I don't even start tapering the patches until somebody actually stops smoking. What does that mean? That means I'm treating with meds in people who are actively smoking, right? Like ongoing tobacco use is not a reason to withhold nicotine replacement therapy. It's not actually a reason to withhold meds at all. And we don't do this in other areas of healthcare, right? Like your blood sugar's up, I can't give you insulin. No, actually, no. Like we do this in healthcare all the time. Is we will treat the condition even if somebody is not yet in remission. And so the same is true with tobacco product use, right? We would treat with nicotine replacement therapy even while somebody continues to smoke. Now, the question, this is where it always comes up. What if somebody has too much nicotine? Right, what if they're using the patch plus the gum or lozenge and then they vape or they smoke? What if their blood level of nicotine gets too high? Well, nicotine has a relatively short half-life, and conventional nicotine products, nicotine replacement therapy plus vapes or cigarettes, usually relatively quickly titrate. That is to say, if you start to become have nicotine toxicity over what somebody's inherent tolerance can handle, they'll start to become nauseous. If it gets really high, they'll start to vomit. And the last thing you want to do when you're nauseous from nicotine toxicity is have another cigarette. So in other words, what it will do is it will people start to feel ill, and then they'll kind of self-titrate down. They'll stop vaping, they'll stop smoking, they'll stop introducing new nicotine into their body. Within an hour or two, the nicotine blood level then drops to the point where they're no longer having that acute nausea. So there's, and it's not universal, but there's almost sort of this like self-titration mechanism where people will stop using nicotine products when they begin to experience nicotine toxicity. And then if the patch really is just too high, if somebody's only using like a small amount of nicotine every day, and the nicotine patch was too high, then you can always pull down the dose, which is why it's important to check in with people on their response to the medication. And the other trick with dosing is I ask all of my patients, how many cigarettes do you smoke a day? And I estimate 1 milligram per cigarette. If someone's vaping rather than smoking, I ask them what's the strength of the pod and how long does the pod last? They get a 20 milligram pod. Is that they go through that once every 2 days, once every week? And then it gives me an estimate of how many milligrams per day of cigarette or of tobacco products are they using. And I dose nicotine replacement to meet or even a little bit exceed that. So if somebody's smoking a quarter pack a day or using 5 milligrams of nicotine through vape a day, they get a 7 milligram patch. If it's half a pack, which is 10 milligrams of cigarettes, 10 cigarettes or 10 milligrams worth of cigarettes, or half of a 20 milligram pot, they get a 14 milligram patch plus a 2 or 4 milligram gum or lozenge. So I tend to meet or even exceed the amount of nicotine that somebody's using. Because if I use a 7 milligram patch on somebody that's smoking a pack a day, that's 20 milligrams of cigarettes a day, it's not going to cut it. They're still going to experience nicotine withdrawal. So I pretty assertively treat tobacco withdrawal with an assertive amount of nicotine in order to keep somebody out of withdrawal that doubles the chance that they're going to successfully stop using tobacco products, when they're ready. I feel like the previous speaker already covered a lot of the ground on electronic cigarettes. I'll just say, the FDA did approve electronic nicotine delivery systems as a smoking cessation aid. The studies they used to do that were relatively short-term and observational, and we don't have decades of literature understanding the real safety of electronic cigarettes. So whenever I prescribe anything or recommend any treatment to somebody, I look at risks and benefits. And it is not difficult to transition people, or I shouldn't put it this way. It's relatively straightforward to transition people from conventional cigarette use to electronic cigarettes. Not everyone makes that journey, but there are a lot of people, it's not that challenging to make that transition for a lot of people. But the safety of electronic cigarettes, really, we just don't understand where it is on that. I really like Dr. Taylor's slide. If we don't know where it is on the kind of safe to unsafe spectrum, certainly not enough, I think, to warrant a definitive practice guideline on the use of an electronic nicotine delivery system. And there is this Lancet article. It's a little old now, but e-cigarettes. You can transition people to e-cigarettes, but that doesn't mean that people stop using them, right? E-cigarettes themselves are not really. They might be able to make a dent in transitioning people off of conventional smoked tobacco, but they are not really validated as their own quit smoking cessation devices. There's people that end up vaping, continue to vape. And what we're left with is the same meds, counseling, and support, right? It's the same FDA-approved treatments that are validated to help people transition themselves off of nicotine products. Now, this is a lot of what I covered is, clinical level, right? Like what an individual clinician might do. But there's a big impact of the context. That is, what is the system surrounding tobacco product use? So I would highlight our facilities, our outpatient clinics, our residentials, or treatment should look at their tobacco control policies. That both emphasize access to smoking treatment. Smoking treatment's a really important component of delivering mental health, substance use, and other treatment, and also a really important component. And a tobacco-free campus policy is also a really important component, because it doesn't matter how freely available meds, counseling, support are. If the minute somebody leaves group or minute somebody leaves appointment, they walk out through an exit full of tobacco smoke where they're triggered to use. Right. So it means creating entry and exit points that are tobacco-free. Now, I'm of the opinion, actually, that you can set up an entirely tobacco-free campus. And if you do this across a system, it won't keep people from going to treatment. And helps support people making quit attempts, because there's fewer places where people will be triggered to use. But even if you do keep designated smoking areas, the idea would be that these are sequestered away where people who are looking to remain tobacco-free won't have to regularly encounter in their course of going to treatment. There was a 2019 study that looked at patients in residential treatment exposed to a comprehensive tobacco control program, and that had a significant increase in their use of tobacco treatment, decrease in the average number of days that people use tobacco, and increase the average number of cigarettes used a day. What does a tobacco-free campus look like? Well, you can split it into what is the tobacco-free environment, what is the enforcement, what is the screening, education, and treatment services, and what's the policy organization. And this is all actually spelled out on the SCLC, Smoking Cessation Leadership Program at UCSF, where I get a lot of my inspiration. So the tobacco-free environment basically provides for no use of tobacco indoors, where on the campus grounds are expected to be smoke-free, and ideally it would be everywhere. No tobacco product use in vehicles or in program-sponsored events, and specifically prohibit staff and patients from smoking together. And this could be a big area of discord in treatment programs that are used to having that type of, but you want to leave treatment for treatment settings, as opposed to people being able to access their counselors or other staff through smoking sites. So those are, I think, like the basics of a tobacco-free environment. And then having, general enforcement for for patients or staff or visitors, understand what the consequences are, establishes designated individuals that actually enforce tobacco-free spaces. The screening, education, and treatment is, I sort of already mentioned, screening for tobacco use at intake, removes tobacco product use from patient possession at intake. It's still their property, but it's in their property, not available to them. Make sure that there's a patient education curriculum, that there's staff training, general smoking treatment, referral to smoking treatment, outside services like quit lines if necessary, that there's on-site smoking treatment programs, including behavioral health treatment and medications. And then the policy organizations is who sees it, what's the communication of the policy, where do the printed materials and signage, that there's some understanding that this isn't meant to be draconian, but that the environment that it's important to protect a tobacco-free environment for people to engage in care. And their policy should include all tobacco products, including vapes or electronic cigarettes. And smokeless tobacco products. That talks about enforcement and adoption dates, and the individuals identifying for reviewing and updating the policy. In 2008, New York State set their policy that all of their addiction treatment programs needed to be tobacco-free, including the facility, vehicle, and grounds, that prohibited patients and family members from bringing tobacco products onto campuses, that there were patient, staff, and volunteer and visitors needed to be informed, prohibited staff from using tobacco products while at work, established a tobacco-free policy for staff, established treatment modalities for people that use tobacco, and there was training in both tobacco and nicotine prevention and education. Dr. Geidish, actually, at I think it's UCSF or UC Davis, but one of the UCs actually published the findings, which was patient smoking decreased modestly after New York State instituted its policies. And again, it was across the entire New York State OASIS contracted treatment system. Outpatient programs didn't seem to change any of the measures in staff survey measures, and methadone program staff use of tobacco-related practices increased. And residential patients were more likely to report having quit smoking after the policy implementation. At 5 years, there was a decrease in staff smoking prevalence, and the mean cigarettes per day among among patients admitted to treatment facilities decreased. Patients in 25 clinical trials network addiction treatment programs found comparing programs that had smoking policies with those without, that the smoking decreased from 92.5% in programs without smoke-free policies to a little over 2/3, 67.6% in programs that did. The rates of staff and patients smoking together decreased substantially. The cigarettes per day decreased, and tobacco services received by patients increased. So the point is to say it is absolutely feasible to develop program policies supporting smoke-free environments, and to deliver and offer smoking treatment in the context of mental health and substance use disorder treatment settings. If you were like, this is great and I want more, smokefree.gov is a wonderful national resource. I mentioned Bill Wilson and the 12-step treatment, but there is a Nicotine Anonymous, the other NA, right? Not the Narcotics Anonymous, but the Nicotine Anonymous. That has virtual groups. A lot of my material comes from the UCSF Smoking Cessation Leadership Program. There's the Behavioral Health for Tobacco Free organization, also hosted by UCSF, and I do not recommend light or natural cigarettes. They're carcinogenic and just as dangerous. Smokeless tobacco is also carcinogenic. E-cigarettes are expensive with limited safety trials. And my mentor, Dr. Connery, where I did my residency, just says, don't quit quitting. Right, it takes time for people who, for individuals that might be using tobacco products to transition away from those tobacco products, particularly for people who have mental health conditions and substance use disorders. So don't quit quitting. And I was asked to go for about 45 minutes, and I think I'm ending on time. So this is my email address, bhurley@ucla.edu, which is where I'm a volunteer faculty. And if you were like, this is great and I want more, the American Society of Addiction Medicine annual meeting is going to be in Florida this coming April. I would hope to see as many of you that would like to attend there. And this is where my conflict of interest comes in of promoting ASAM. So take that for what it's worth. But it's a wonderful meeting, and looking forward to seeing those of you that are able to attend there. I think at this point, I will transition to see what questions people have.
Thank you, Dr. Hurley. Just a little bit of background for North Dakota. We have 8 human service centers in the state health hospital. They went tobacco-free several years ago, so that's great. Really nice standard. And through our cessation programs, we do have a local substance use behavioral health center that is tobacco-free, and they made it a point to include the vape products because you never know what could be in them.
That's right.
So, we're seeing more and more behavioral health staff be interested in offering tobacco treatment, and it's a priority population for us with our CDC grant. So I think this information is very timely because it's a population that just hasn't had that downward trend like the general population.
It really hasn't, and it's possible. Like there's this sometimes fatalism. Oh, yeah, it's not worth addressing. I assure you, it's worth addressing, right? Yeah. And it's feasible to do so.
And I actually did look up your conference earlier today. I was curious about it, and I saw it was in Florida. It sounds wonderful, and I'm going to keep it on our radar because we have a few cessation grantees. I think their work could be beneficial for other places to learn about. So,
would love to see that. Would love to see that there.
Yeah, I don't have any specific questions, and I don't know if any of them.
So I just pulled up the Q&A, so if I could take a crack. Are there any studies on the use of e-cigarettes in pregnant patients and the effect on the fetus? I'll be honest, I did not prepare to answer that question today, so my best answer is I don't know. But my more elaborate answer is I'm unaware of any specific e-cigarette or electronic nicotine delivery system studies on pregnant patients. The conventional wisdom is that nicotine is vasoconstrictive, so I would expect it to be associated with intrauterine growth restriction. That said, it is the most harmful part of smoking is the polycyclic aromatic hydrocarbons that come in the smoke, or other ingredients, the polyethylene glycol that come in the vape, right? Nicotine itself, despite its vasoconstrictive effect, is not known to be particularly teratogenic. So the conventional wisdom is if you have a pregnant patient who continues to use tobacco products, that they get counseling and support. Right? That's the what's the right term? The first line treatment. But if you're maximizing out counseling and support and the person's still using tobacco products, to use nicotine replacement therapy. That would be next, because the safety of nicotine replacement therapy is again, well established. Not well established in pregnant patients, just to be clear about that, right? NRT wasn't evaluated in patients with pregnancy, but the conventional wisdom, it's probably better to use nicotine replacement therapy than vaping or smoking, certainly than smoking. But the same unknowns about how safe really is electronic nicotine delivery systems. We did see youth hospitalized with interstitial lung disease in response to vapes, so we know that they're not entirely benign. The safety profile of vaping in pregnancy is just not well known, as far as I know. But again, I didn't come prepared to be talking about electronic nicotine delivery systems in pregnancy. Another question was, what is it in the nicotine patches that cause nightmares? Nicotine. Nicotine causes nightmares. And it's interesting, you can also get nightmares with varenicline because varenicline activates the nicotine receptors. So there's something about the nicotinic acetylcholine receptors that when they're tickled in the way that nicotine tickles them, it seems to be associated with nightmares. There's a question about off-label medications. So there is some off-label evidence for clonidine and some of the tricyclic antidepressants, I think nortriptyline. We have a number of FDA-approved medications. The algorithm that I use relies on those rather than off-label medications. I will be honest that I have not personally had a lot of success with clonidine or tricyclic antidepressants. But that said, there is a small evidence supporting the use of them. I would probably only use clonidine if I had another reason to use clonidine, right? So when would I be using clonidine? Sometimes I use clonidine as an off-label medication that helps reduce anxiety. If I needed to get somebody's blood pressure under control, clonidine lowers blood pressure. Clonidine gets used all the time for people that are going through opioid withdrawal and not being treated with buprenorphine or methadone. So you can use it adjunctively or for opioid withdrawal management, although outcomes are much better using buprenorphine or methadone for opioid withdrawal, but if I've got another reason to use clonidine, then certainly will. It tends not to be my first go-to, which is combination NRT plus bupropion, or maybe varenicline instead of the nicotine patch. So there is some evidence on the use of these off-label agents, but I don't want to highlight it as being so robust that I would use off-label medications before trying the on-label medications first. And if I've maxed out meds and somebody's still like, I have never had a situation where people, what's the right term, were maxed out on meds and continued to use at the same level. Usually smoking goes down, and it's then I'm trying to think what is still tripping somebody up, right? What is still getting in somebody's way? And then I try to figure out what that is and address it. And now I do think that was all the questions that I saw in the Q&A.
Yep, I think that's it. All right. Well, thank you so much for joining us.
Thank you. Thank you so much for having me. I really appreciate the invitation.
You are missing a fairly warm day. For winter, it's 33 degrees.
I'm looking at behind you. It looks much warmer in the graphic behind you than I imagine it is right now.
It would be kind of white and dirty looking for snow. So, yeah.
Well, again, thank you so much for having me.
Yeah. Thanks so much for joining us.
All right. Take care.
Thanks. Neil, did you have anything you wanted to say? Or shall I wrap it up?
You can go ahead, Kara. I just was, wanted to thank all of our presenters today. That was a lot of great information we had, and thank you for arranging all this, and thank you everybody for making time to attend. This is how we keep this going, and hopefully we'll have a lot of people joining us tomorrow on day 2. And today 2 is going to have a little more of a policy focus to it. Today was more of the treatment, more of the medical part of it. We will have some great speakers from the state and from the Public Health Law Center. And I think of that because we just got in a question about any thought on synthetic nicotine. One of our presenters from Public Health Law Center will be touching briefly on that tomorrow. It's a very fresh topic for us. So hopefully we can get some answers for that. And we will make these recordings available in the future. So anything else from you, Kara, that you wanted to bring up?
No, just please fill out the evaluation. It's in the question and answer section of this. So we'd appreciate your feedback. Thanks for attending. It was a great turnout.